Whenever you're ready, Kevin.
All right, just to clarify, you can see my presentation correctly? Yeah. Okay, sounds good. All right, disorienting my screens here. All right, so just to get started here, so I just thank you so much for the introduction and for inviting me to speak today. I'm actually very excited to present our newest work that was just recently accepted for publication in Neurorehabilitation and Neural Repair on Saturday. So just stay tuned for the full text article that should be coming out in the next month or so. So if you have any questions or comments or personal experiences, I invite you to kind of pop them into the chat whenever is a good time. All right, so in today's talk, I'll be discussing the epidemiology and pathophysiology of COVID-19, the potential benefits of exercise for individuals with COVID-19 and stroke, and the development of our clinical considerations for stroke rehabilitation. So as we all know, the COVID-19 pandemic is attributed to the SARS-CoV-2 virus, which was first reported in December 2019. And as of September 2021, this evolving pandemic has resulted in more than 231 million cases confirmed worldwide and more than 4.7 million deaths. So if we extrapolate these data with pooled estimates from stroke studies, this equates to more than 4 million COVID-19 cases who present with a new onset of cerebrovascular event, either acute ischemic stroke or intracerebral hemorrhage. So obviously everyone is at risk for COVID-19, but children and older adults are at particular risk, and individuals with coexisting comorbidities like stroke and cardiovascular disease increases one's risk of infection and disease severity and mortality after COVID-19. So while the acute and short-term signs and symptoms of COVID-19 like fever, cough, myalgia, headache are frequently reported after infection, there's now emerging data highlighting that there's major multi-system complications following infection. So these include respiratory, cardiovascular, hematologic, and neurological sequelae that may persist 6 months and more after infection. So the media has now kind of portrayed these individuals as long haulers or individuals with post-acute COVID-19 syndrome. So best practice guidelines endorse interprofessional stroke rehabilitation programs for mitigating post-stroke health complications. But in light of the COVID-19 pandemic, mitigating risk factors and morbidity associated with the short and long-term consequences of COVID-19 is a critical of importance. And we know that exercise training is effective and a recommended component of stroke rehab. There's a lot of data, strong data supporting its effectiveness for functional recovery, like mobility, muscle strength, cognitive function, improvements in cardiorespiratory fitness, reductions in cardiovascular risk factors, and markers of neurorecovery as well. But because of the COVID-19 pandemic, stroke rehabilitation professionals are now facing challenges with the implementation of exercise in stroke rehab. So stroke rehab is not the only aspect of stroke care that has had significant challenges during the pandemic. And Marcus and Brandon in 2020 recently published a statement regarding COVID-19 and stroke care. And they found that the pandemic has led to significant reductions in service delivery and stroke medical practices, and as well as reductions of in-person and center-based activities just to limit viral transmission because of the virus. So now specific to exercise following COVID-19, there are several guidelines and clinical decision-making tools that are published and available for the general population, for athletes, for cardiac rehab, but there's nothing specifically outlined for stroke rehabilitation. Which brings me to kind of the objectives of this paper and our presentation today, which is to first describe the multi-system pathophysiology of COVID-19, to discuss the potential benefits of exercise for individuals post-stroke after COVID-19 infection, And I'll also walk you through how our team developed clinical considerations related to COVID-19 for exercise during stroke rehabilitation. And we're going to dive into some safety considerations, pre-participation screening, and exercise prescription. So in these next few slides, I'll be taking you through a journey of pathophysiology of COVID-19 and 3 major steps from transmission to infection. So SARS-CoV-2 is transmitted via aerosol droplets and respiratory droplets. And as you can see here, this characteristic spike protein is kind of the culprit and the novelty of the virus. And this kind of immediately binds to the nasal epithelial cells as it kind of travels into the nose and mouth. So as the virus travels further down the airways, it continues to invade cells that express a nice receptor called angiotensin converting enzyme receptors, or ACE2 receptors. And these receptors are found all over the body, including cells in the lungs, the endothelial cells in the vascular tissue, smooth muscle cells, and several other cell types in the body. And it's this binding to ACE2 receptors that facilitates viral invasion and cell replication. So if we zoom into the alveoli, which is an important site of gas exchange, we see that there's an immune system response, and they do a good job of identifying the virus and kind of mounting up an intense immune response to try to eliminate the imposing threat. So that's in step 1. However, this triggers a cascade of events leading to a cytokine storm, which is essentially just an exaggerated release of circulating cytokines, immune cell hyperactivation, and reactive oxygen species. Now, this can lead to life-threatening systemic inflammation and multi-system dysfunction, which I'll be kind of walking you through in the next slide as well. So most notably, and of concern for stroke recovery and rehabilitation, the complex multi-system effects of COVID-19 and cytokine storm share potential commonalities with known pro-inflammatory and multimorbidity profile of individuals with stroke, namely through an increased oxidative stress and inflammation, cerebrovascular and cardiovascular dysfunction, decreased lung volumes as capacities, and muscle weakness and atrophy. Which brings us to this question. Can exercise help mitigate or improve the multi-system dysfunction of COVID-19 in someone with stroke? And I'm going to give you a hint, it might help. So from a clinical perspective, exercise training may counteract or improve the multi-system effects of COVID-19. And in the stroke literature, there's data to support that exercise training may improve markers of neurorecovery, cognitive function, neuroplasticity, and pulmonary function. So markers of ventilatory efficiency, lung function, and peak oxygen uptake. And there's actually strong evidence supporting the benefits of exercise training for improved cardiovascular function, reductions in systemic inflammation, and reductions in cardiovascular risk factors. Gains in functional capacity like mobility and muscle strength are also seen in the literature as well for people post-stroke. Now that we know that exercise is likely to be beneficial, how can we help healthcare professionals with implementation? So the first thing we did was conducted a systematic literature search in 4 databases to figure out if there's anything published related to stroke. We reviewed articles related to COVID-19, rehabilitation, clinical practice guidelines for exercise on COVID-19. And there was, out of 391 articles, there was nothing found relating to stroke and exercise rehabilitation. So what do we do now? Well, we have to create our own. So in the absence of stroke-specific guidance, we developed an international panel of clinical and biomedical experts in stroke rehabilitation, exercise physiology, and neuroscience and neurology, spanning in Canada, the United States, and in Europe to try to develop clinical considerations for stroke rehab. We synthesized new guidance by extrapolating relevant guidance from other populations, mainly cardiovascular disease, with pre-existing aerobics exercise guidelines specific to stroke. Our considerations help kind of inform clinical decision-making for the implementation of exercise from pre-participation screening, prescription, and progression. And these kind of are made beyond the current 2019 guidelines and more specific to the current context of COVID-19. So let's dive into the guidelines here. So first, we would just like to acknowledge that, like, obviously the COVID-19 situation and the volume of patients requiring care varies significantly from region to region, from country to country. So the following recommendations are not meant to be something that's absolute or definitive. It's just more as a guide to be considered in kind of the context of your current local, institutional, and public health guidelines. We also suggest that before exercise sessions, you track symptom onset, you maintain physical distancing and ventilation where possible, you practice high standards of hand hygiene and use of personal protective equipment, and you conduct COVID-19 testing prior to rehab if possible. So the first step of exercise prescription is pre-participation and screening and eligibility. So this is an interprofessional team approach spanning from OTs, PTs, MDs, respiratory therapists, registered nurses, whereby all health professionals have a role in kind of determining whether someone is safe and suitable for exercise participation and graded exercise testing. And this is especially true in the context of COVID-19. So to help determine pre-participation screening, we've actually created a questionnaire and an algorithm that can help determine eligibility for rehab and to assist with clinical decision-making. So I'll be going through these in the next few slides here. So to assist with the pre-participation screening, we developed a COVID-19 screening questionnaire. And the idea here is that this questionnaire can help identify potential respiratory, cardiovascular, neurological, and musculoskeletal effects of COVID-19 that might cause contraindications to exercise. And the idea is that clinicians would administer this questionnaire prior to commencement of exercise rehabilitation. We have also developed an evidence-based COVID-19 decision-making algorithm for pre-participation screening and eligibility. And this chart goes hand in hand with our COVID-19 pre-screening questionnaire. So what's important to note here is that the green, yellow, and red kind of boxes are following like a red light approach. So green, you can proceed, yellow, you proceed with caution, and red, you stop and make decisions. So this algorithm helps identify whether someone with stroke is eligible for exercise rehab and the steps required based on someone's COVID-19 symptoms and status. It can also help assist with clinical decision-making about whether further medical assessment and/or exercise testing with ECG or metabolic gas exchange is required before participating in exercise. So I acknowledge that not everyone might be familiar with exercise testing and prescription, but I've put up this picture here just to familiarize everyone with kind of the ideal situation that you would have in your lab or in your hospital or something like that in your clinic. So in a perfect world, prior to exercise rehab, we would conduct an exercise test using VO2, gas exchange, electrocardiogram, and blood pressure measurements. And the idea behind this test is that it helps us out by ruling out abnormal exercise findings, might provide us with clinically relevant information like the capacity for someone with stroke to physiologically adapt to exercise, especially graded exercise, and baseline measurements of cardiorespiratory fitness and ventilatory efficiency. However, this is not always the reality, as we've identified in the recent scoping review published in 2020 in the Journal of Neurological Physical Therapy. And given the potential large volume of patients, not all practice not all practice settings will have this type of equipment or qualified personnel to conduct this exercise testing. But a symptom-limited test or some maximal exercise tests might be clinically feasible and could be included as a part of pre-participation screening and for someone with stroke. So it doesn't have to be like a full-blown exercise stress test with all of these measurements. And I'm going to be discussing this in the next couple of slides. So how can we conduct exercise testing safely? So even though you may not have all the fancy equipment in that previous slide, it's important to obviously have awareness of someone's vital signs. So heart rate, blood pressure, SpO2. And this is a time where it might be helpful for you to collaborate with interprofessional team members to gather relevant medical history. And they also might have this type of equipment to monitor some of these outcomes as well. You should also be aware of exercise termination criteria outlined by the American College of Sports Medicine. And particular attention should be placed on symptoms such as moderate to severe angina, changes in oxygen saturation below 80%, blood pressure changes, so specifically like a drop in systolic blood pressure during an increase in workload, exertional dyspnea, and any abnormal changes in ECG if you have an ECG machine. Nonetheless, though, in accordance with current exercise recommendations, clinicians are required to objectively monitor heart rate, whether it's via heart rate monitor, ECG, or manual palpation, blood pressure responses via manual sphygmomanometer or automated blood pressure measurements, oxygen saturation with pulse oximeters, ratings of perceived exertion and dyspnea throughout the test. And these things should be recorded in charts so that when you do repeat tests, you're able to kind of identify whether there's good changes or bad changes with your exercise program. And really the overall goal here is to provide safe and individualized exercise prescription for someone who might be at risk for abnormal responses to exercise. So I'm sure a few of you are wondering, when is exercise testing with ECG suggested? And really the need for monitoring cardiac rhythm via ECG should be based on someone's medical history. If they have cardiovascular disease or atrial fibrillation, for example, their COVID-19 history, and the presence of post-acute symptoms, namely cardiovascular symptoms. So a nice review published in 2020 by Majid et al. Highlights the effect of viral infection on cardiovascular outcomes. And these are namely through systemic inflammation that might lead to downstream myocardial infarction or myocarditis, which might also increase someone's risk for arrhythmias. So to kind of summarize, the use of ECG should be used for individuals post-stroke who might have potential underlying or unknown cardiovascular pathologies, specifically because ECG might provide us with information that is diagnostic or pathologic regarding myocarditis, exercise-associated desaturations, hypoxemia, and maybe even exertional dyspnea. So once you conduct the test, what's nice is that you get an individualized exercise prescription and dosing parameters. So how do you get that? So the objective test gives clinicians the ability to identify heart rate max, heart rate rest, changes at peak heart rates, which essentially helps us identify a dosing parameter and exercise training intensity. It may also help us identify potential adverse effects of exercise, like I kind of already mentioned in the last slides, including exercise-induced oxygen desaturation, potential exercise intolerance and dyspnea, and even ECG abnormalities as well. So now that we know how to conduct an exercise test and how to use the results of the exercise test, I'm just going to dive into a little bit of exercise prescription for this population. So for asymptomatic and mild cases, so there's currently a lack of high quality empirical evidence for exercise rehab post COVID-19 for all populations and stroke included. But in line with previous expert consensus COVID-19 recommendations, and considering the potential immunoprotective benefits of exercise, specifically low to moderate intensity exercise, we recommend that a gradual increase of exercise training volume and prescription should be based on, of course, clinical exercise stress testing, clinical judgment, symptoms, and symptom severity. And in this case, submaximal exercise testing is a valid alternative, just depending on if there's any cardiovascular, potential cardiovascular comorbidities. For moderate to severe cases, clinicians should encourage a gradual increase of exercise training volume, starting at 50% of frequency, intensity, and time. And this should start 2 weeks after symptom resolution. And a few things to consider is does this person have cardiovascular or other important symptoms that might result in abnormal exercise responses? And this recommendation is very consistent with cardiac rehabilitation guidelines that suggest starting at 50% of the previous workload. So just to summarize some key points, our considerations incorporate the best available evidence in exercise physiology and clinical judgment in stroke rehab to guide the implementation of exercise rehab for individuals with stroke. We supported our clinical considerations using pre-COVID expert consensus stroke rehabilitation guidelines and relevant information from cardiac, pulmonary, and general rehabilitation guidelines. So based on the current literature and depending on patient volume and available resources, exercise testing with ECG and gas exchange should be conducted for people post-stroke with moderate to severe symptoms or individuals who present with some potential cardiovascular pathologies. And lastly, objective testing yields individualized exercise prescription and safe participation, which should be the goal of all of our it should be the goal of our exercise prescription. So I'd like to thank all co-authors of this work. It was truly a team effort from individuals all over Canada and the UK and in the United States. And I just would like to I'd like to thank all of you guys for your attention today. And I welcome any questions or comments or any personal experiences. Thank you.
Perfect. Thank you so much. We can take questions in the chat, or if you'd like to raise your hand, and we can do some verbal questions as well. So feel free. Oh, we have one hand. So Dr. Baudrias, you can go ahead.
Yes, I was wondering why you start with the cardiac guidelines instead of looking at the encephalite myalgic population, which is the viral base of rehab. So why did you start your recommendation using more cardiac and pulmonary symptoms?
So that's a good question. During the development of our exercise considerations, there was nothing published for COVID in terms of chronic, you said chronic encephalitis, myeloencephalitis. So that's part of the reason why we based our recommendations on cardiac and pulmonary guidelines. I'm sure at this point, there might be some more guidelines out there published that we could consider in the future. But that's essentially why there was not much we can base our guidelines on. So we did our best in that regard.
Okay, so you haven't been testing it yet, or have you? No, okay.
Testing the exercise guidelines?
Yeah.
No, not currently in our lab at McMaster in Hamilton, just because of the COVID pandemic. We haven't been able to get back into the lab, but maybe Lyndon can elucidate some of his comments after this for his experiences.
Okay, because what we observe, we open a long clinic, long COVID clinic here at the Jewish Rehab Hospital, and in the very severe case, I mean, we really have patients that have trouble to, step out of their bed and walk to their kitchen. So, when you mentioned this 50% of, exercise from their maximum, it's really hard, you know, it's really tough. And with this population of encephalite myelite myalgic, then there's also, you know, these crash. So if you push them too much, so yeah, I'm just wondering, like, all these, maybe this protocol could evolve with that, because in clinic, I mean, it's very debilitating what we see in this patient. And I don't see in many cases, or we could even do 50% of their max, right? So yeah, I'm probably here recommending that this should probably be updated with some more recent data on you know, this specific population that is viral based. Yeah.
Yeah, that's a good comment. And just to clarify, it was 50% of the previous workload. So say someone was working already at 50% of their max during rehab, they would be recommended to start at 25% of their.
I see. Yes, I see. Okay, that would make more sense. Okay, that sounds good. Yeah.
And then you would only do that. You would start very progressive, and you would start at the 20. Like, say for example, you would start at the 25%, and then you would build your way up and like appropriately based on their symptoms and stuff like that, and how they're feeling.
And do you recommend any functional testing? So, you know, there's the Newcastle and some. So I guess these, you know, the questionnaire that you put forward, are you using it also after? So you're doing pre and post. So is it kind of your outcome measurement using that questionnaire?
So the questionnaire is not necessarily an outcome measure. It's more of a tool to kind of identify if there's new symptoms that might occur throughout their kind of their recovery. So it's more of like a screening tool, just to make sure that there's no new cardiovascular symptom that might come up with exercise training. So it's not necessarily an outcome measure, but it's more of a screening tool. In terms of other functional tasks that might be relevant in this population, I'm thinking like maybe a 6-minute walk test to maybe get a sense of their aerobic capacity. It's a proxy measure, but it could be done in a lab environment, social distance and all that stuff, or even like a 10-meter gait speed test. So those are a few that I was thinking from like an objective perspective.
Thank you.
No problem. Thanks for your questions.
Yeah, I want to add something. This is Mark. So I think Marie-Hélène, you asked a good question, but in the algorithm, I mean, one of the things that we did in this paper is we reviewed the pathophysiology of COVID and also the pathophysiology of a stroke to see if there were overlaps. And we have a section on neurological consequences of the disease. And we take these in consideration when you look at the algorithm and the flow chart to make decisions. So obviously, we're not proposing that everybody, you know, can start at 50% of the previous workload. But if you follow the flow chart, you'll see that we take into consideration any consequence, neurological consequences, but also cardiovascular consequences of the disease. But you need to read the paper really to understand the flow chart and the algorithm.
Okay, we can go with Lyndon's question.
Bernard's can jump in.
Yeah, it's actually me. Thank you, Kevin. That was fantastic work, honestly, and very much needed. Because I think like all of us that we work with this population and basically doing these cardiovascular interventions, we were a little bit, you know, doing things as, you know, without guidelines, but trying to, you know, pull out from different guidelines. And I think this is very much needed, not only for this pandemic, but maybe for future, right? Like I just wanted to, it's not about specifically about this paper, but I wanted to ask you your perspective regarding if fitness levels before COVID infection in this population in stroke, if you think that they could play a big role in terms of how would you prescribe after this like 14 days of infection, and also maybe I don't know if now there's more evidence. I'm sure that you're more updated than me on this, but if you think that high levels of fitness in stroke basically also can mitigate the severity of the infection of COVID-19, or if there's anything out there.
Yeah, those are good questions and comments, and I appreciate your kind words about the work that we've done. So for your first question, obviously in a perfect world, it would be ideal to have baseline VO2 measurements for your participants that have stroke. So say you have someone that's in an exercise program already, they have a baseline VO2 measure of, let's say 20, and then they get COVID, and then you do a repeat repeat VO2 test for like once they're eligible for rehab. I think in that regard, it would be helpful to determine exercise prescription to see where they lie. So are they now at 10 VO2 after COVID, or are they at 15? Like it might be a good way to kind of assess how much COVID has truly impacted their cardiorespiratory fitness. And there is data to support that people that do have COVID will have reductions in fitness. So I don't know if that fully answers your question, but it could be used as a way to maybe adapt or tweak a little bit, use your clinical judgment to maybe use a little bit more of a personal approach if you have those two baseline measurements that to kind of refer to. So I don't know if that answers your question about that. But in terms of high intensity exercise, so that's a little bit tricky. So I would say low to moderate intensity exercise is kind of ideal in the early stages of inflammation, of infection, just because it's immunoprotective. So it doesn't bring on pro-inflammatory markers. Whereas there's some data, albeit it is very limited, there is some data to suggest that high intensity exercise may induce kind of like a pro-inflammatory response, which might actually be detrimental for the immune system. So those are just things to consider when you're implementing exercise training, is just consider like their status post-infection. How are they feeling? Maybe if you can have access to blood work to see if there's any inflammatory markers that are elevated, like interleukin-6, IL-1, those types of things. So again, I'm not sure if that fully answers your question, but
yes, no, it does. It really does. And also like I guess that the stage post-stroke is not the same like having COVID when you're like in acute or subacute and when you're more chronic stages, because also we know that there's this kind of window of recovery, which it's more in the subacute stages. So I guess that if you get COVID in this subacute stage, you may want to not just stop exercising. Okay, you want to, of course, like be exercise, but safely when the symptoms of COVID are starting to temper down a little bit. But I think this is very interesting because basically, yeah, it really depends, I guess, about the symptoms of severity and the stage of a stroke. So a lot of factors play a big role here.
Yeah, 100%. I totally agree. And that's part of the thing, right? We if someone, like I said, there's 1 to 2% of COVID cases get acute stroke. So we want to be able to implement exercise safely so that we can kind of tap into those improvements post-stroke and that window of opportunity you're talking about, for sure.
Thank you, Kevin.
Yeah,
Great job.
Thanks.
Is there any other questions? I don't see any other questions. I'll just check. Okay, so thank you so much, Kevin, for the presentation.
We had
Oh, is there a question?
Sorry, Kevin just reminded me. So yeah, actually we want to just implement that. The guidelines that we have proposed, obviously it's dependent on situation, but I think something a lot of the clinicians, especially from the JRH, and can point to is that they have experience in conducting an exercise training program during COVID as well. Maybe not in the sense of recovery from stroke, but during COVID. And I think some of the things that we want to impart is that it's possible to implement these things. We've had some experience in our lab of doing this. Also, we're fortunate in that our research projects involve exercise stress testing in particular, but in particular also like the continuing monitoring infectious potential COVID infection, and implementing measures like social distancing, PPE. Even with some of the exercise stress testing, we involve sterilization of equipment and use of filters. These are all methods that we can implement right away and have been implemented to a point at the GRH anyway. But I think there's more that we want to kind of go into, and there's obviously the flow chart is a good guideline, but I mean, we can always continue to implement and improve these methods as well. But I think it's something that it's a challenge for us to adhere to, but we hope we're doing a good job, and we hope to continue to do a good job of, maintaining a good record in terms of screening and eligibility, and, maintaining proper measures while COVID is ongoing. But yeah, we just wanted to say that we're doing it so far in the lab, or we're trying to implement it, but there's always room for improvement, and we're always looking to find ways to improve as well.
Perfect. For those who want to receive the recording, I'm just going to ask you to write your email into the chat so that I can send it to you. And if there are no other questions, we're going to end the presentation here. So thank you so much, Kevin, for taking the time and to present this to everyone that participated today.
Awesome. Thank you so much for having me, and for all the good questions. I appreciate it.
Perfect. We're getting some thank yous in the chat as well.
Thank you, Kevin.
Thank you.
Perfect. So everyone have a great day. Thanks again.
All right. Thanks so much for having me. Appreciate it.
Okay, no problem. Thank you so much for doing it. It was really interesting.
Awesome. Great. Have a great day.
Thanks, you too.
Bye.
Bye.